Good afternoon, everyone, and welcome to today's Research America Alliance discussion. My name is Taylor Lopez, Communications Director for Research America, and I'd like to thank you all for joining me on Zoom today and for your partnership in the Research America Alliance. If your organization is not a member, we invite you to stay as our guests, but please get in touch with my colleague, Joel. He's happy to connect with you to discuss the value that comes along with being an Alliance member organization. You can find his email in the chat. Now, today, in honor of Public Health Thank You Day, we are very pleased to be joined by epidemiologist and leading public health expert, Dr. Oscar Alleyne. He's the managing director of the Public Health Division at MITRE. Now, as always, you can type your questions into the Q&A box or the chat, and we'll pose as many as we can during the Q&A portion of today's session. Thank you so much for joining us, Dr. Alleyne. We have quite a bit I'd like to cover in roughly the 45 minutes that we have together. So I want to start us off with integrating people-centered approaches to deliver public health services. Now, we've seen that this approach is not just about treating diseases, but also about placing individuals and communities at the center of healthcare delivery, fostering empowerment, inclusivity, and tailored interventions for better health outcomes. So I want to ask first, how can the needs and preferences of individuals and communities be better assessed in the design of public health services?
Thank you. And first, I want to say thank you to every last public health professional out there on Public Health Thank You Day. It's been some challenging times, but some rewarding times as well. So just an honored to be here and have this conversation with the broader community of practice, as we say. You asked a very interesting question about the role of the community-based input and the community evaluation in the theme of not only research, but also in the delivery of public health intervention, strengthen the health and wellness of communities. And to strike that answer, I would say the biggest way we truly have to embrace those tenets is by really embracing those community level inputs, right? We are in the business of people, beginning, end. We're in the business of people. So we can't construct solutions. We can't just divest ourselves from the people-based approaches and the impact that may have. And some of the best models that I have seen have been truly integrative by ensuring that individuals, communities are part of the plan and process. Nothing for us, but by us, right? In that regard, ensuring that when systems are being designed, when hypotheses are being rendered, when whether it's a research imperative or an opportunity to develop a public health intervention strategy, one must make sure that there's representative of those communities that will be impacted at that table, involved in ensuring their ideas are heard, gauging their input and their impact, because ultimately we're not going to be successful in creating things in a vacuum or in a quote unquote laboratory space without necessarily involving those in the dynamic nature of those communities and the populations that we serve.
Great. And, we're learning more and more that, the public and patients, we need to integrate those voices into, the research that we do. So I kind of want to get more into that public health research space. How can the perspectives and experiences of the general public and patients be better incorporated into research? Are there new research techniques that better incorporate the community's perspective into those public health interventions?
Yes. Yeah, excellent question. So two-part answer to that. I'll give two quick examples to help strengthen the message to that extent. I look at the All of Us campaign, how that was really focused on trying to elevate the participatory realm of making sure individuals and communities are represented in kind of clinical data research, because there weren't. And that really required on the ground, visible exchange, talking with communities, ensuring that they understand their security needs, their data access points, and that there's a sense of ownership from beginning to end. The second is where I would call the Community Data Initiative, kind of around it's kind of called, it's an initiative that CDC and others and HHS have used. They kind of shorten it to say CODI. So it's Clinical and Community Data Initiative program. And what that does is recognizes that communities themselves track and store health-related data, in addition to the data that you get from healthcare, research, and other those particular base incentives. But the problem is how to standardize, link, and reconcile those resources as information while at the same time preserving privacy. So this kind of CODI initiative looked at how to bring local individuals, organizations, collaboratives, as well as the governmental, public health, and the healthcare elements to really support that community effort to build and ensure that data and data-driven approaches are inclusive, but that they can produce tools that both ensure standardized models for individual record keeping, larger aggregate review, and of course the privacy element to ensure that personal identified information doesn't necessarily mean that individuals put themselves at risk, but by virtue of working across this kind of distributed health network, you're able to not only implement research, have a coordinated data centers, and locally based queries that allow that kind of local viewshed to be seen, while at the same token tying into the broader health construct, both on the healthcare and the public health side. So those are two elements that I would say are good examples of regionalizing as well as organizing from both a state, local, and national perspective, incorporating of local communities in addition to the research imperatives.
Great. And, just speaking on that community piece, and I want to talk about equity-centered public health data. So public health research, it pretty much sheds a light on health disparities among different populations, and it pretty much helps us to understand the root causes and develop interventions to reduce inequities in access to healthcare and health outcomes. So could you tell us, what is equity-centered public health data, and how can it help to mitigate health disparities and racial injustices and pretty much improve population health overall?
Thank you for that. The way I answer that question is going back in what we sometimes call our public health commandments, our 10 essential public health services. Those of us who understand or train in public health, there's a circle that really illustrates both the various slices of how public health is integrated. And central to that is this term of equity. And why we say equity sometimes mean different things to different people, but having an equity-based approach to ensure that data collection, data integration, and data analytics have that focus and that foundational element in mind. Why? Perfect example of how we collect data. Sometimes we want to make sure it's across a continuum. Other times we want to make sure it's reproducible, that we're able to compare it over the course of time. And another area is one that I would say reduces some of our flexibility. And all of those things I mentioned have to be shifted when we're thinking about an equity-based approach. Why do I say that? Perfect example. When we look at an indicator such as race, right? We have been following this particular scientific, or I should say, institutionalized based approach to this concept of race. But our communities have changed over the course of time. And their viewpoint around race and how one will self-identify does not fit the modules or the process that we've had over time. So that puts us at a little bit of a disadvantage. We, as researchers, public health strategists, public health, applied public health professionals, when we're looking at data with this kind of construct that does not match what our present community-based approaches look at, regard themselves and self-identify, it becomes very difficult to recommend strategies, recommend interventions, or identify solutions to improve the health of populations when we're using indicators that do not speak to those particular communities in a way that properly helps them be identified. And another particular example of that is the fact that when we take these elements in place and we're not looking at the equitable or the disadvantage that oftentimes our research or our strategies or our thought processes are put into place, we oftentimes do harm. And one of the biggest things that we should always be reflective of is no matter what we do, we should not be doing harm. So I put those in kind of elemental ways to really address, but the equity-centered approach allows you to change the thought process and how one is in thinking about solutions, how one is thinking about descriptors, how one takes indicators in a way and ensure that they themselves are not part of the problem, but that we're able to readjust and be flexible in the way we are truly doing data visualization, data analytics, and community-centered approaches for the solutions that we have in our sector.
Right. I think community-centered approaches is something that a lot of public health professionals are, realizing is something that we need to address these different disparities and these issues in, these different underserved or marginalized communities. So in what ways can public health professionals do a better job of incorporating the voices of marginalized communities to lead to more equitable research?
One of the first things I would say is that we need to abandon the perspective of having a paternalistic way of looking at things, right? And I say that with respect to, we know most of the public health professionals are very, there's a significant amount of empathy, there's a significant drive, and there's a fire in our bellies for improving the health and safety of communities. Oftentimes, however, we can't speak for others unless we have incorporated their lived experience, or we've really have integrated a theory of change in the way we design and we approach our problem solving. So that, from the perspective, I think allows us to be more flexible in when we are looking at particular problems and coming up with solutions. I can't come up with a solution or recommendation for a research topic. And let's say, for example, I want to increase the mobility of in an aging community of use of, let's say I use the example of self-automated vehicles. Sounds like a novel idea. Individuals, are getting older. They may not have the ability to drive themselves. So to have these kind of self-automated vehicles may be a solution as a research idea that we can implement for the solution-bearing outcome. However, let's think about it from the lens of the actual population. What if we have a rural leaning community where access to these vehicles are not readily available, or we have the other social terms of health with respect to economics or other particular elements that actually say this solution, this idea, is actually creating more of a disparity because it's only for those who are affluent or have the ability, and not to those communities, like you mentioned, marginalized and others, who themselves have other particular factors that are impeding the ability for this solution to bear fruit. So those are the elements that I speak to in trying to provide that example, to say and to suggest that we need to be more flexible when we're thinking about these particular solutions and research ideas, because if we're truly trying to improve the health, safety, and wellness of communities, we have to make sure we're lifting the collective and not being lopsided with respect to who we're actually immediately impacting as a whole.
Absolutely. And, I want to shift gears a little bit to infrastructure. There's been a lot of attention on the US's public health infrastructure over the past maybe 2 or 3 years since the beginning of the pandemic, really. And I'd like to ask, what is the current state of our country's public health infrastructure, and how did investments made during the pandemic help to modernize this infrastructure?
Excellent question. I would say that it's a complex answer.
Mm.
Several reasons. Sector and the healthcare sector, everyone has, I think I froze. Can everyone hear me now?
Yes, you're back.
All right. Sorry about that. So the infrastructure has been siloed. There's been differences of design and how databases are covered, how, this access point may be for a chronic disease, several for communicable diseases, and not necessarily as interoperable as we have and we want and desire. So there's been investment prior to the pandemic on data modernization, how to make things a bit more fluid in the way data can be exchanged between healthcare providers, electronic case records, the systems themselves that exist within agencies like CDC, HHS, HRSA, all of these elements, even CMS, for example, all of these individuals and groups and programs had data points that were not communicating with each other. With the advent of the need for rapid access to data, as we saw with the pandemic, to make better decisions, the investments over time, we're hoping are making things better, but we recognize it's still at a pace that's not as rapid as we would like. So how do we shift in a way to ensure that the investments in both the architecture, the IT, the ability for the various agreements like TEFCA, Helios, the various tools, Digital Bridge, that really try to improve the exchange of information from a health record to a provider, to a clinical decision support, to a public health authority? How do we make sure that all of the collective do have the requisite means and that is reproducible, right? That it's able to be expanded. Now, it's complex because it's not just as easy as flipping a switch and saying the problem is solved with a federal mandate. Each states have their own surveillance systems, have their own ways of how their data is integrated, and cross-jurisdictional elements are also an area of concern. So there's been a move to improve by open architecture, cloud-based technologies, secure kind of imperatives to ensure that the systems are designed in a way to keep the data private and secure, while at the same time allowing for the bi-directional sharing of information, especially for public health authorities and healthcare authorities as a whole. So it's a big, it's a big salad, and I would hope that the salad continues to be a little bit tasty and remains fresh. But we do recognize that on top of this infrastructural needs, there's the other necessary element of training the workforce alongside it so that we can maintain both our competencies and our ability to strengthen our capabilities and our designs so that while the systems are being improved, the public health, the individuals who are part of that data science, that modernization, they're also being improved at the same token.
Right. And I think you're absolutely right. This whole thing is just extremely complex. And I think, but we also know that, modernizing these systems requires robust investment in our infrastructure. So I'd like to ask, how can we leverage public health research to boost investment in our infrastructure even further?
Yeah, there's this concern that we have about the pendant cliffs, and we use these analogies quite often. Now, I would say from the pandemic to now, we have seen an increase in funding to the public health and for the public health system. But we recognize, and we've all already seen when that funding dries up. Now, the question becomes, how do you ensure, as you mentioned, continuous support, continuity of effort, and sustainability in these investments over the course of time? Now, with these cliffs, meaning as the federal agencies themselves may receive funding through Congress that are disease specific or hopefully non-disease specific, but are kind of structurally based, the sustainability concern is, will that die off? Will that drop if there's a different attention that's being played, if there's political powers that, continue attacks on public health to that extent and minimize the progress that has been made? Those are things that are very clear threats to the system. And to your question, we need to recognize that they may need to be alternative mechanisms designed for how we support our total health infrastructure. So this is the role that research may play, in addition to identifying areas of interest for dynamic changes or improvement in health and safety. Perhaps the implement of those policy implications on how we in the research world can help elevate and identify the various pathways to re-energize, continue funding, and identify ways that we can truly maybe develop how do I say it, independent of a governmental only funded mechanism, whether it's the private industries, the academic worlds. These are areas that I think are going to be really important for us to design a public health system of tomorrow.
Great. And, that sounds, perfect. And, I want to touch back on just pretty much how the pandemic, illuminated so many different issues, and not just health disparities, but the country's lack of modern interoperable data systems, pretty much affecting data collection, sharing, and analysis. What, if any, could you tell us are some of the emerging technologies that are being explored for public health data modernization?
Yeah, ONC, the Office of the National Coordinator, CDC, and several others have been engaging in spaces to try to identify what are the core standards that are going to be necessary for interoperability, for example, data exchange, the use of electronic case records. Prior to the pandemic, there was a great initiative called Digital Bridge, which brought in electronic health record vendors, healthcare providers, billers and payers, in addition to public health entities, as well as academia, to try to find ways of lifting the ability for communities, or I should say entities within these jurisdictions, to receive data and share data in a much more in a much faster way, with more completeness of data integration, as well as the ability to make decision making. So all of those elements, I think, are going to continue to be important. As I talked about TEFCA, right? The Trusted Exchange Framework and Common Agreement. There's e-health exchanges. There are all these elements that are going to be important for us to look at what's working well. I mentioned Helios earlier, which is a consortium that's trying to identify not only standardization of data elements, but how interoperability can be truly baked into these systems, so that we don't have continuation of our siloed approach, how to make these systems as fluid and as interoperable as possible, so that the moment you walk into a provider's office, or you may have a wearable device that is monitoring, for example, your cardiac or your diabetes case management, that your provider has the opportunity to receive information to help in the clinical decision support for your care. The researcher is able to access information to therefore give better recommendations for research initiatives and suggestions for strategic interventions. And the public health authorities, they themselves are able to utilize that information in a condensed way to truly ensure that they're looking at the effectiveness of the interventions and the programs and services that the individuals and the collectives are also responsible for. So it's that global village that I think is really going to be important for us to continue these foundational supports in a way that gives us some effective data and shows the continuation of our improvement over time.
Absolutely. And so this is data that's being collected. So there has been a huge spotlight on trusted science, and how there's been this pretty much a decrease in the trust in science in different areas. And of course, like that is a major issue. So with this collection and data, what processes are in place to ensure the accuracy and reliability of public health data?
I'm back. I froze.
Just a bit. Sorry, I can repeat my question.
I think I got your answer. I think I got your question. You're asking about the trusted data and misinformation to that extent. Did I capture that?
Right. So the data that we're collecting, how can we ensure that that data is accurate and reliable, to disseminate to the public?
Yeah. The question is interesting from the lens that we in the research, and as an epidemiologist, I always remember we try to recognize that data had an apolitical stance, meaning You just review data, you just do the observations, and you put your findings out there. And whatever policies or how people interpret it, that's up to them. I think there's a moral imperative and a social contract that we have as researchers and public health professionals to really ensure that we are provided information that is not twisted from the lens of the differences of opinion, but that we maintain that trusted advisor and trusted partner lens and title in a way to ensure that one, whether we certify our systems, two, when we are describing and providing our information, we recognize that it is for the common good of the community as a whole, and that we are not making recommendations that are fearful of political injects, but that we are recognizing that for the social good of communities, for the moral imperative that we have in improving community and population health, that when people are taking data and misappropriating its intent or describing things in a way that we know was not the intent of the researcher, that we actually stand up and illustrate that there is a standard in our approach that should hopefully fight against the impact of mis and disinformation, because ultimately, if we cannot secure and ensure that our position is strong, is firm, and is devoid of these particular, I would say,
I don't think we might have lost you again for a moment.
do not have a laissez-faire approach to how our data is looked at or how the conclusions that are drawn, but that we do speak up, because the other side of not only doing the research is the applied nature of what we do that I think will help us in the long run.
Perfect. So I want to shift to now getting that feedback. How can feedback and insights from public health practitioners and different policymakers be integrated into those data modernization efforts?
So as part of the community collaborative, as part of the approach, we do ourselves we don't do ourselves a good service by only speaking within our circles. We have to expand our reach outside of our comfort zone. I was at a conference, APHA, where one of our past presidents and very strong, voice and advocate mentioned that there are times where you have areas of discomfort, right? But people run away from the discomfort because they don't recognize that the discomfort is actually where you have your biggest area of potential growth. So my point being, in making that analogy to your question, having policymakers in the room, ensuring that we have a lens of engagement, not only with the communities, but with the folks who are not our standard partners. It could be businesses, they could be private industry, they can be a whole host of folks, because it is imperative for us to ensure that what we do doesn't only resonate in the halls, in the rooms of our own colleagues, right? We have to expand ourselves beyond the realm of our own comfort, because the best thing that I remember as being a local epidemiologist was walking into a community and explaining to them the core concept of epidemiology. And over the course of time, seeing them being empowered to speak to it themselves, having a better understanding of how to look at data and communicate that in a way that was digestible. That's how we became successful, not by just using our language in a way that only we ourselves understand, but that others can capture, can integrate, and further adopt into their understanding, so that the policies that they in turn are responsible for have those elements in mind. The programs and services that they may have helped to fund have those concepts in mind. That's the way I think we're going to be successful, by integrating those folks at the outset and not just waiting towards the end to say, now that we're done, let's go have this communication strategy that may or may not work.
Absolutely. And, we're coming up on time, so I just want to, I want to move into this last question before we get into Q&A from our audience. So, for the past 18 years, Public Health Thank You Day has helped to raise the visibility of the field and recognize those public health professionals, both here and abroad, who keep us healthy and safe. So I want to ask you, how can we, whether that be the general public or the public health workforce, how can we effectively advocate for increased support, resources, and funding for critical public health needs?
We have to be vocal.
Mm.
Another analogy that I would say to the answer is public health had the superpower prior to the pandemic, and its superpower was the invisibility cloak. It did its work, and it just moved on to the next thing. There was no fanfare. There was no, look what we did. Look, we solved the problem and kept on moving. And as a result, people would either know public health when there's a crisis, but not know it when there's the steady state. And that invisibility cloak.
Just give Dr. Alleyne a moment to get back.
For us, the more people know about the broad support and the reach of public health over the course of time, the better we are in what we can expect in the future. So I would say the visibility cloak is great, but we may have to get a microphone to add to it to make sure that people truly understand who, what we are, and how they're part of our broad-based solutions.
Great, excellent answers. Thank you, Dr. Alleyne. I'd like to now ask my colleague, Jacqueline, to join us on screen to share just a few questions from the audience. Jacqueline, do we have any questions from our audience?
We do. Thanks, Taylor, and thanks, Dr. Alleyne, for this wonderful discussion so far, learning a lot. So first question from the audience. Can you suggest how we can improve acceptance of vaccines in various populations? How can we do better in combating misinformation in public health?
Yeah. So vaccine hesitancy started out as a thorn and has become a really difficult sore. When we think about the role of vaccines, they have always been one of public health's greatest triumphs. Being able to stop polio, being able to stop malaria and all of these other diseases over the course of time for generations, only to have a swift shift to this lens where we're now seeing a resurgence of vaccine preventable diseases and others that really can benefit the health and safety of our communities by virtue of mis and disinformation or just general resurgence in data approaches that, or I should say, conclusions that are misaligned and misguided. Can vaccines save lives? Absolutely. Should we be concerned that we're seeing a rise in childhood vaccines hesitancy? Of course, because at the end of the day, that just makes our population more vulnerable than what our parents' population or our older generations were. And it's very difficult to identify a one strategy or model. What really needs to take place is a truly concerted and integrated approaches, one where we build in peer-to-peer exchanges so that the individuals who would trust their information, where they're getting their sources from, we're able to counter the bad information with good information, or with at least enough information that folks can make a better informed decision. Illustrating once again the positivity, the effectiveness of how vaccines can and continue to save lives against this counter arguments that vaccines are dangerous and therefore people don't want to take them because of the perspective that vaccines do harm. this is something that has been near and dear to my heart, and I don't know how I can speak more to it other than truly ensuring that we are elevating ourselves with the skills, with the data knowledge, and the addressing those areas clear on, directly head on, with respect to not shying away from countering the bad information with more complete information and data, proof in existence, getting a support mechanism for those places where people get their data, and ensuring that we have a great counter argument, and as well as analyzing what are the indicators that lead to these beliefs around that cause and increase the vaccine hesitancy. We have to do a better job at understanding why people think this way and why they make their decisions, so that we can have some better strategies for countering them.
Great, thanks. A lot of great points you made there. So also on the topic of misinformation, so a two-part question. How has misinformation impacted the inclusion of underrepresented groups in research? And how has misinformation impacted the willingness of people to share their data?
It's two-part, right? The part of the misinformation is based on some truths. And now let me explain what I mean by that. Communities who are marginalized, communities of color, tribal communities, et cetera, have known that there's been a history of medical apartheid, medical displacement, or in the sake of science and research, things that are done that have been harmful to those communities, whether it's Tuskegee, Henrietta Lacks, Native American populations, not having to fight to get their data and their DNA and all these clinical data sets, et cetera. All of this has shown that over the course of time, people have gained a mistrust for research or how research has been used against them. So that's the truth. Mm-hmm. The misinformation and the continuation of that misinformation is where we have an opportunity to be honest about the history, reconcile the impact of that, while shifting and ensuring that we have a better
Dr. Alleyne just froze again. Just give him a moment.
Sense of both ownership of the responsibility of what was done in the past, with a clear partnership approach for what needs to be done in the future and why it is important, and ensuring that there are fail-safes, that your trust can be continued to be built when the community and those folks in particular are able to find out that you are keeping to your word, you are maintaining that sense of partnership, and that the outcomes are not one that help exacerbate issues that we've seen in the past generationally, but that we can look towards for the present and the future.
Great, thank you so much. Next question. What do you see as the biggest challenge to an integrated public health and healthcare system that can really protect the public's health?
Ooh, it's a really good questions. Biggest challenge. One of the biggest challenges we have is, of course, the ability to work well together. I usually have the statement that when we talk about the improvement of data modernization and the data standards and the healthcare delivery, whether it's private, primary care, public health, et cetera, oftentimes those partnerships are not well thought out. I use this description that, for example, when the ACA was developed, all these healthcare providers were pushed towards electronic reporting, but public health was left out of that equation. So they were always trailing behind. Likewise, with the data modernization efforts, there's this huge, push on population health, where the healthcare providers, everyone has a data system. Everyone has a way to reflect their population, which is basically their cohort. But but still the broader aggregate approach continues to be a little bit slower on the uptake. So how can we ensure, and then when we talk about the biggest problems that is preventing us from being successful, is how we can recognize these siloed-based approaches, even when they're generated for the sake of solutioning, whether it's a healthcare provider system, a primary care provider system, a public health system, a federal entity system, or an administrative system. How can we ensure that when we're talking about working together, all cards are on the table to ensure that we are not just vested in keeping our legacy systems in place and owning our own data, but that we recognize this data is going to be communally supported, communally derived, and raising that population-based health approaches up from that level versus the disparate ways that we've been engaged.
Great, that makes a lot of sense. And I think we only have time for one more this afternoon. So is related to data, or is there an emphasis on improving data literacy within the public health workforce?
Oh, definitely. I would say that data literacy, data visualization, data science upskilling should not just remain within the public health workforce of now, meaning we have to train those individuals here now. But we also know there's a need to create a pipeline for the future. That means when we are training individuals in these data sciences, research-based initiatives, we shouldn't just wait for it to be at a graduate education level. It should be at a collegiate level, undergrad, and even more importantly, further upstream, it should be within the STEM programs, the basic science and learning, because you generate those interests from that lens. You allow, as people, those cohorts grow over time and build their skill sets. By the time they make it into the workforce, it ensures a robust, planned, thought out, and integrated model to ensure that we have enough available within our pipelines to fill and sustain our need.
Wonderful. Thank you so much. Oh, sorry, he froze again, but I'm not sure if he is done answering the question.
Yes, we can wait and see if there's anything more to this fantastic answer.
Did I freeze? I froze?
Yeah, just for a moment.
Okay. Even things such as AI and the use of AI, and there's a lot of concern there, but there's also opportunity and prospect. So all of those, I think, are ways that we can truly train not only our existing workforce, but invest in our upcoming workforce to make us all successful.
Great, really good point to motivate our public health workforce and our future public health leaders. So I'll turn it back over to Taylor.
Great. Thank you, Jacqueline. And thank you so much, Dr. Alleyne. You made such fantastic points from beginning to end. I can't thank you enough for being here on this very special day, Public Health Thank You Day. I've certainly enjoyed this incredible discussion. And thank you to our audience for your thoughts and participation. So before you go, I'd like to invite you to join us on Wednesday, November 29th at noon for an important Alliance discussion on suicide prevention, featuring renowned speaker and suicide prevention researcher, Dr. Philip Baden from the University of Texas at Arlington School of Social Work. Dr. Baden is a leading expert in the field. He has vast experience, including in the social determinants of health, adolescent health risk behaviors, and substance use and mental health outcomes. We've invited Dr. Baden to speak with us about his research on the relationship between adverse childhood experiences and suicidal behaviors in children and adolescents as we work toward a stronger understanding of suicide prevention and how to support those in need. You can register for that chat through the link in our chat. Again, I want to thank you all for joining us today. We look forward to seeing you again soon. Take care.